My name is Tabtila Chowdhury, and I'm a third-year medical student at Michigan State University College of Osteopathic Medicine, and this is my case report on subacute combined degeneration of the spinal cord with nitrous oxide inhalant use in an elderly patient. So inhalant use is very well documented amongst adolescents as being the second most common illicit substance used right after marijuana. Examples of inhalant are glue, gasoline, and nitrous oxide. And although there are multiple studies on inhalant use and abuse and its side effects in adolescents, there's not a lot of documented studies done on elderly patients. So nitrous oxide is commonly used as an anxiolytic and analgesic, especially in dental procedures. Colloquially, it's referred to as laughing gas and illicitly as whippets, which are small canisters that people inhale for euphoregenic effects. The most common side effects are neurological side effects causing myeloneuropathy, SCD. It can cause psychiatric symptoms, sexual dysfunction, and bowel and bladder dysfunction. Although the exact relationship between why nitrous oxide causes SCD is unknown, it is known that nitrous oxide does oxidize the cofactor B12 ion, which further inactivates the B12's function in numerous biochemical pathways, including myelin synthesis, which can promote to why it can cause SCD. So our patient is a 72-year-old male who presented to the ED with a 3-week complaint of bilateral upper and lower extremity numbness, tingling, and recently acquired gait imbalance requiring the use of a walker. The patient stated that the gait dysfunction, paresthesia, bilateral lower extremity weakness, and back pain began in the morning after he removed carpeting from his home. So of note, his past surgical history was positive for total hip arthroplasty and a biopsy showing tubulovillous adenoma in 2013, which he never had a further GI workup of. So the patient hospital course was pretty benign. He came in with vital signs normal, subjective numbness in his extremities, gait unsteadiness, no spinal column tenderness. Neurological exam was ANO times 4, cranial nerves 1 through 12 intact, motor 5 out of 5, strength, sensory. The MVP was diminished bilaterally in lower extremities but intact in bilateral upper extremities. His labs and imaging of EKG and chest X-ray were benign. His CT of cervical, thoracic, and lumbar did show diffuse disc degeneration and moderate to severe spinal stenosis. So on admission, neurology and neurosurgery were consulted, and neurosurgery took the lead, saying that a lot of these non-specific neurological findings could be chalked up to chronic degenerative spinal disease, and they don't recommend surgery at this time. So upon further persistence by the patient, who was just like, yeah, I've always had I've always had this chronic back pain, but I've never had these neurological symptoms before. Something happened like 3 weeks ago. So we did a full workup. We found that his vitamin B12 was really low at 104 and magnesium was low, and MRIs of the CT L showed patchy T2 stir hyperintensity of cervical, thoracic, spinal cord involving the posterior dorsal columns. Hence, we gave him the diagnosis of SCD. The patient was given 1000 mcg vitamin B12 IM injection every day for 3 days and started on gabapentin 200 milligrams 3 times a day, to which drastically improved his symptoms, and he was discharged home after a few days to go follow up with his PCP requiring the B12 injections or oral B12 supplementation. So why this case was important is because inhalant abuse is very common amongst the adolescent population, and even amongst them, it takes 2 months for them to fully regain function after inhalant abuse caused SCD. So we're not even sure how well our patient, who's 72, is going to recover. Or if he's gonna ever fully recover to his baseline again. This case report also explored the presentation of inhalant abuse in an elderly patient and how commonly it can be misconstrued to be caused from disc herniation or nerve impingement or even stroke. A limitation in this case study is, of course, that this is only done in one 72-year-old patient. So, of course, other older patients may use inhalants and completely present in a different way. So in conclusion, we have to be very alert, and we have to identify reversible causes of B12 deficiency, never rule out inhalant or drug use in elderly patients, and compare the presentation differences of inhalant use in youth versus the elderly population. We have to understand the importance of B12 supplementation in regards to reversibility of SCD, especially in this population who's already at risk of falling. We have to explore inhalant abuse, presence, symptomology, reversibility, and irreversible implications in the elderly population, and the potential fall risks and the sequelae that may occur with falls after inhalant abuse.